Bismillahirrahmanirrahim. The next station is about treatment-resistant depression. So Mr. Smith wants to speak to you about Mr. Smith, a 32-year-old gentleman who was admitted to your ward with the diagnosis of recurrent depression, and he was treated with fluoxetine 20 milligrams, which was increased to 40 milligrams daily with no improvement at all. Or antidepressant was then changed to venlafaxine, about 150 milligrams daily, and his wife is extremely worried as he's not making any progress. Is not making any progress, and she's worried about she's worried about she's worried about his significant weight gain on his medication, and she's fixed an appointment with you, and to discuss her husband and treatment options as well. So address her concerns. So it's an information giving station. So ask, what do you know about Mr. Smith, and what treatment he was on, and what's your understanding, and why the treatment is not working. And then tell her the cause, that sometimes it happens over the course of the treatment that the depression treatments don't work. It's about because of the genes that depression may be very quite it can become untreatable because of any cause. We don't know the uh, exact cause as such, but can be due to some people are prone to become more depressed than others uh, from their genes, and some people and that's the genetic. And then sometimes stresses don't let the people come out of depression, and there's a chemical imbalance as well. So sometimes it is out of proportion, and people can't come out with antidepressant because the chemical imbalance is quite severe. And also about vulnerable personality. Some people are uh, personally, like their personality is like that they are more vulnerable as compared to other people, and the chemical imbalance, etc. um, so genetic stress, vulnerable personality, chemical imbalance, and then maybe medications. Sometimes can be due to medical illnesses, and sometimes it can be due to alcohol and drugs. So medical illnesses and alcohol, drugs. So what are the causes of treatment? So, enlist the causes which are which can be responsible for the treatment resistance in case of depression. So the causes may be genes, maybe stress, maybe chemical imbalances. So anything that cause depression can also keep the depression and keep it and prevent it from getting better. So, and that's one thing you can understand that. So in this case, genes, stress, chemical imbalance, and medical problems, and pain, and sometimes can be pain, sometimes can be alcohol, drugs, and medical problems. Uh, so, and vulnerable personality. So personality is also very important role in treatment resistance. Now, when you have told, then you explain and address our concerns. Their weight gain unlikely due to venlafaxine. You also explain that side effects from venlafaxine, that usually there's maybe dry mouth and insomnia, nausea, headache, high blood pressure, had dizziness, sexual side effects. So high blood pressure, but weight gain is very, very rare due to venlafaxine. So you need to do some blood tests to investigate the cause for the weight gain, and maybe hypothyroidism, and emphasize blood tests and examination. Address concerns, role of psychological treatments, and suicidality, risk of self-harm. So what is the role of psychological treatments here, and what's the suicidality and risk of self-harm? Uh, so then you tell that in treatment resistance you can give psychological treatments, you can give lithium, but again it's associated uh, with weight gain. Uh, so you say that if he doesn't want, we won't be giving him lithium, but we can give him liver tryptophan. We can give him psychological treatment, and if he's comes out to be hypothyroid, then we can treat it with the thyroid hormones like triiodothyronine or thyroxine. And suicidality and risks of self-harm. So suicidality and risk of self-harm. So just ask about uh, like there is a risk, and if they are concerned, the person can come to the hospital or can be treated in the home by the home treatment team as well, and it's a treatable thing, and people do get better. So augmentation, a combination treatment, and all never ever forget, never ever forget ECT. It's a combination of different antidepressant like venlafaxine. So what are strategies here? You can add you can add mirtazapine to venlafaxine. You can add lithium. You can augment it with triiodothyronine. You can augment it with levotriptofan. You can augment it with bupropion. You can augment it with you can augment it with ECT. You can augment it with psychological treatments, psychotherapies. So this is treatment-resistant depression that can help. That can have it can yeah occur in some of the cases that depression may be treatment resistant. And the second task is of ECT. So whenever the station comes about treatment-resistant depression, never forget ECT, never forget psychological treatment, never forget anything. So always keep in mind the ECT. Now the task was address concerns, and whenever address concerns the task, you must do something. Not only address concern, but also explain the management, and that's the hidden task in address concerns. And whenever so and in the first task usually. If there is a if the both the tasks are of address concerns, maybe in the first task you can take in the first station you can take some history, but this was the first station that was an explanation station. So both stations can be explanation stations, and you must be like whenever you address concern, you should explain some of the treatments and management plan. Now is your turn in the second station. Now it's your turn to explain the ECT, because what happens in the second station, related task in the second station, Mr. Smith has now been treated with venlafaxine, with a fluoxetine 40 milligrams daily for 6 weeks, and then venlafaxine 150 milligrams for 6 weeks, but has not improved. He did comply with these treatments, so there was no non-compliance. Your team has decided that he's treated with ECT, and he has very little knowledge about ECT, and you're asked to give the patient the information about ECT with a view of assisting him in deciding whether he's willing to agree to have the procedure or not. Address patients' beliefs, concerns, and expectations about the treatment. That's the question. Then you're not required to assess his capacity to consent treatment. The candidate is expected to discuss nature and proposed treatments, number and duration of treatments, discuss efficacy and side effects, and discuss alternatives. So ask what he already knows. That's the first thing. Some courses don't explain that. So you have asked, then explain the rationale behind the ECT, that there were there were two treatments which hasn't worked, and ECT is a treatment which works. Do you know anything about ECT? Then go on explaining that this work and depression will lifts up usually, works in most of the people. Depression lifts up, people go back to their normal life and active life. They can lead an active life, things like that. and also discuss what the procedure of ECT entails and ECT workup. So you tell about the workup, the anesthesia, and suitability about the ECT, and going to the ECT suite, 5-minute procedure, small, sophisticated kind of electric current is passed. A risk of death is only 1 in 50,000 or to 100,000. So it's equal to having a tooth extracted under general anesthesia, not more than that. And anesthetics takes care of the physical part of your treatment, physical side of your treatment, and it's not a barbaric treatment. And so there will be about 9 to 12, like 6 to 9 sessions of ECT given in twice a week or thrice a week, with a difference of 2 or 3 days between each ECT. You can withdraw consent at any time. The side effects are like headache, confusion, sleepiness, and memory loss for some time. But usually memory loss comes back. If that's a concern, you can give ECT to one side only, not to the other side. And that's how ECT works. And you have to continue with the medication at the same time when you're giving ECT, and even after the ECT, you need to continue the medication. So vomiting is another side effect which can occur due to ECT, and muscle aches. So headache, muscle aches, vomiting, dizziness, slightly confusion, memory loss, sleepiness. Not a legal form, can withdraw consent at any time, and unilateral ECT can be considered. Discuss alternatives. So what's the alternative ECT? So any question, anything you are explaining, any treatment, just mention the alternative treatments as well. Like desensitization will be the alternative. The alternative will be CBT. So ECT, the alternative will be again, it will be CBT. So any treatment alternative can be CBT. Interpersonal therapy, what will be the alternative? CBT. Even in interpersonal therapy, there are alternative treatments available. Or give them adequate time to decide. It's the source of information, leaflets, websites, talk to the nurses, etc. Now, the anorexia nervosa station. Miss Kate Lewis is a young woman who was previously diagnosed with anorexia nervosa in the past. Currently, her weight is normal. She went to the GP and reported that she feels like losing weight as she stressed for the last 1 month, and take the family and personal history from her and assess physiological factors for illness. Do not take a history to establish diagnosis of anorexia nervosa. Do not perform mental state examination. In the next station, you will discuss with student nurse about the etiology and management of her illness. Now, to say and don't make a diagnosis of anorexia nervosa, but you have to ask some questions related to current pattern or current eating pattern and some of the symptoms of anorexia nervosa. Although you don't need to establish the diagnosis, and you may ask some questions about the mental state, well, not all the questions. So the main is a family and personal history. So you ask about the question about that. I understand that you suffer from anorexia nervosa, from an eating disorder called anorexia nervosa, and your weight is normal, but your GP feels that you're about to lose weight for the last 1 month. So I'm here to ask about. So anything happened 1 month ago that you're losing weight, and what happened? So asked about the relationship, for how long and what's the extent. Are there any fights? And was she ever in a relationship? What happens to the relationship each time? Why is it ended? Does she describe herself to be an emotional person? And then ask about her family, like her parents. How was it? How was her childhood? How was her mother with her? Was she over expecting? Was she were involved, and how was her father with her, and was he under involved at all? Were there any difficulties with the father? How was her schooling? How was her um, mm, uh, was she overweight in school? Did she lose weight in school? Did she ever have an illness in the childhood for which she has to lose weight? And was she appraised when she lost the weight? And did she use any kind of drug or alcohol or anything like that? And uh, how the relationship with her sister? Is she a high achiever and attractive? And how was she in the past? Did she ever receive any treatment for anorexia nervosa in the past? Does she have any? Does she get ever depressed? Does she harm herself, etc.? And psychiatric history of anorexia, history of losing weight during stressful times like exams, and precipitants and current stressors, relationship breakdown. Summarize the problems identified and etiological factors. So that's how you go. You can ask about personality as well. So personality and maybe personality, alcohol, and drugs, and you have certain the relationship breakdown, a past psychiatric history of anorexia nervosa, losing weight during stressful times like exams, and past history of anorexia nervosa. So these are basically the points you need to cover in the station, um, and the current family history of anorexia nervosa. That's also very important. So not only from family dynamics, but family history of anorexia nervosa is also important, and how her leisure activities, like does she read any magazines or things like that. And the second station is to uh, talk to nurse Miss Linda Taylor to explain the etiology and discuss the management of Miss Kate Lewis's condition. The candidate is expected to explain the etiological and the etiology and discuss the management of this woman's condition. The candidate is also expected to discuss the predisposing, precipitating, perpetuating factors for an illness, and they should also discuss the treatment options for conditions, so nature of her illness, anorexia nervosa, and common presentations. So always the treatment station, the second station, must always start from their history and then diagnosis. So tell about the etiological factors and her diagnosis, and then come to the management. And also, so history, diagnosis, etiological factors, and then maybe predisposing, precipitating, and perpetuating perpetuating factors. Uh, so perpetuating factors, and then treatment options, so biopsychosocial, multidisciplinary team, dietitian involvement, endocrinology team, prognosis, body image distortion if the present, so um, psychological treatment, and management step care approach, so BMI chart, correction fluid, all the medical treatment, and nutritional counseling, input from dietitian, and CBT family therapy, and interpersonal therapy as well. So CBT family therapy, interpersonal therapy, um, IPT, and what else? Psychodynamic psychotherapy, all enlist, and even CAT, like CAT, cognitive analytic therapy, uh, enlist all possible therapies, BMI chart, correction fluid and electrolyte balancing, nutritional counseling, and input from dietitian. So that's it for today, and I'll be back shortly again, inshallah. Assalamu alaikum.